Okay. Thanks to the organization committee for the invitation. So where do we stand in France? I will talk about what we did in France, but I share my experience in Occitanie, my region, where we set up some programs that I would like to share with you and maybe share some thoughts also. So no conflict of interest. So, okay, you know that, but it's important to remind it because that's why we are here and because it's not a partial subject. It's really a huge subject today. And in France, we have 2 million of people with long COVID. We have 2 million of people with long COVID, and whom 30% are complex cases. So why do we need to set up care pathway? I think it is the most important question. Despite the data gap, despite the lack of consensual definition, despite the lack of full understanding of the pathophysiology, despite the lack of biomarkers, despite the absence of treatment, but we need to do that. Because for 3 reasons: medical ethics, scientific knowledge, and socio-economic impact. Very rapidly, we need to give support with patients with symptoms, even if we don't understand all, just because we are doctors, we are healthcare providers, and maybe in 10 years we will say, okay, I was right to be there today. As in HIV, I think I didn't live this period, but I think you had also the same feeling, but we need to be there today. Second, as it has been said, we need to be early in our intervention. If we wait, people are worsening. So we need to identify people rapidly and properly. And that's why I heard about a lot of cohorts with self-diagnostic of long COVID. It can be interesting, but we need precise diagnostic. Otherwise, it will be very difficult to go on. We need to establish a framework for evolving knowledge. And clinical care pathway can help because we can adapt to new research, to new discovery. We can provide cohort of patients for clinical and fundamental research. So we need to set up this pathway, these cohorts. We need to provide standardized and consistent care independently where people are, independently who doctors are, just because it's a principle of equity of care, and we need to try to respect it, even if it's difficult. We need also to give the best practice guidelines for healthcare providers, and also to be sure that money is going where it has to go. And you know that money is a difficult issue, but it's a real issue. And 6, we need to alleviate socio-economic costs for society because we are also citizens, and we know that long COVID costs a lot to the society, so let's try to give a solution. So what is the ideal long COVID care pathway? A lot of guidelines, including Spain, that I didn't put it, have been already published, but there are some common pillars. First, primary care is the foundation of the clinical care pathway, so we need to rely on it. Second, we need a multidisciplinary approach. We need to do individualized care plan if possible, but we need to try to do that. And we need to increase patient education and self-management. And I think the Long COVID Companion app from Luxembourg is a nice way to try to do it. So in France, we validated in May with the HAS the clinical care pathway for adults with long COVID. So you can see, I don't know, no, okay, not a problem. You can see that general practitioner is the first step. And it can be helped also by the post-COVID coordination cells. And in each department in France, we are supposed to have a post-COVID coordination cell, which is reachable for patients to ask for question and reachable also for GP. The diagnosis and management of symptoms are done, and you can have some specialized advice requested. But in complex situations, you can refer the patient to competent center with specialized advice, with multidisciplinary care, with treatments, with research protocol, follow-up, training, etc. And of course, we need the psychological support, we need physiotherapists, we need orthophonists, we need social support. All this is important. And rehabilitation center. The issue is that today we have very few competent centers in France, and we try to increase it. So I would like to share, my experience of what we set up in Occitanie, a 2-year experiment, but which is still going on. So that means that until 2026, we still have fundings to follow the adventure. And Occitanie is the second largest region in France, as large as Ireland, and with 6 million inhabitants. So we had strategic objectives. First, to organize the coordinated care pathway in a territorial manner, because I explained to you that it was very huge. So we induced collaboration between public and private healthcare facilities. We mobilized 13 post-COVID coalition cells, meaning one by department, 15 healthcare territorial community with MDs, nurses, physiotherapists, 6 competent long-COVID diagnostic clinical centers have been labelized, and 18 rehabilitation centers have been labelized also. We established a single departmental phone number to facilitate access to local resources for patients and healthcare workers, and we did some training webinar to increase awareness and formation for the healthcare professional. This is a framework, and to be very short, many of the patients, and so we try to catch up the more complex patients, were managed in an outpatient daycare pathway, meaning that in one day we could do them consultation. If they need RMI, they could have RMI. If they need CT scan, they could have CT scan, cardiological consultation, pulmonary consultation, neuropsychologist. So in one day. And at the end, we had a summary consultation, and so we could give the diagnosis, long COVID, not long COVID, and we see some results after that. We also implemented a tele-expertise capacity for helping GPs with complex situations, and we established a long COVID regional observatory, which allow me to present you some data, not all, of course, but I will present you only the data for the more complex patients that we recruited in our cohort. So 669 patients were included, with a majority of women and the mean age of 46 years old, which is quite coherent. You see that almost 60% of patients were under 50 years old. That a majority of patients were infected in 2020 and 2021, but that more than 47% were infected in 2022, meaning that the pandemic was not over in 2022. And of course, the invisible long COVID pandemic non plus. In terms of representation, we had an underrepresentation of workers and intermediate profession, meaning that we could have inclusion bias, but also it could illustrate some inequality in access to healthcare. And I think we are to be very attentive to that. And most of the people included were living in Occitanie, and they were seen in a referral center in their own department, but meaning that there were only 3 departments with clinical diagnosis referral center. There's a lot of patients probably lost. 92% of patients have the episode of COVID-19 microbiology confirmed, meaning that they really had, for most of them, a COVID. And it was long COVID were confirmed or suspected in majority of patients during the inclusion, but not in all patients. And meaning that we need to be very rigorous when we say that someone has a long COVID. because 7% of patients suspected of long COVID but not having a long COVID, it can be a lot of people at the scale of an entire population. So we need to be sure that people have nothing else. And the mean duration between the initial episode and the starting of the diagnostic pathway was more than 10 months, meaning I think it's something that you know, but it's subjective. And they had a lot of symptoms, of course, at the initial episode of COVID, but also at the inclusion, so meaning almost 1 year after. Okay, main symptom, fatigue, concentration disorder, dyspnea, memory disorder, headache, sleep disorder, very classic. What is more interesting is that after the first rehabilitation care that they had, so a few weeks after the diagnosis, they had a significant improvement, and of course, the different parts of rehabilitation were about fatigue, hyperventilation syndrome, etc., etc. But anyway, you can see over time that you have a slight decrease, but the persistence of symptoms at 6 months. And that you have on this persistence a stability of fatigue, a decrease of headaches, dyspnea, fever, myalgia, but an increase in concentration, memory disorder, and anxiety. So you have a clinical picture with neurocognitive and neuropsychiatric, which is worsening over time. Consequence on work, very important. It's not medical, but it affects people a lot. More than 80% of people were affected on their work. They had stoppage, and you see that duration of stoppage, mean, was more than 4 months, and more than a third of people did not return to work at the inclusion. Okay, very shortly, major impact on quality of life. If you want to, we could talk later, but major impact. And major financial impact. At 6 months, the financial impact was more important than the inclusion. So we need affordable long-care pathway. So how do we deal with a world full of vulnerability, volatility, uncertainty, complexity to set up this pathway? I think we can discuss about it on the panel. And thank you to all these people and organizations, because you just can imagine that if we can go on with this framework, it's because many people and many institutions are involved. And I would like to thank particularly ARS Occitanie, meaning the Health Regional Agency, which is funding since 2 years our framework, Occitan framework. Thank you very much.